Good afternoon, and welcome to Ask the Doc. This is the monthly program where we invite our guests to ask questions of our experts in Alzheimer's disease and dementia. My name is Dr. Megan Whitbracht. I'm the Associate Director of Education at UCI Mind. UCI Mind is an NIH-funded Alzheimer's disease research center. Today, in recognition of Down Syndrome Awareness Month, I wanted to talk about the link between Alzheimer's disease and Down syndrome, the important research advances that have been made, and the work that still needs to be done in this field. And to do this, I've invited on the program Dr. Christy Hom. She's an associate professor and a neuropsychologist at UCI Health in the School of Medicine. Dr. Hom received her graduate education at the University of Michigan and right here at Chalk Children's Hospital. She treats children and adults with autism spectrum disorder. She also treats children and adults with ADHD and intellectual disabilities. And she is the co-leader of the Down syndrome cohort of the ADRC here at UCI, and is a co-investigator of the Alzheimer's Biomarker Consortium in Down syndrome, ABCDS. Welcome, Dr. Hom.
Thank you.
And to our guests, welcome. If you have questions for Dr. Hom, you can just put them in the chat and we will get to them as they come up. So before we get into the research, I wanted to ask you about an important event that happens every September. It just happened last month. It's the Down Syndrome Showcase. Can you tell us a little bit about it?
I would love to. This is an event that we started 3 years ago, and we are now hosting it annually. It's a joint production of UCI Mind as well as the UCI Center for Aging Research and Down Syndrome. And we have performances by individuals with Down syndrome or groups of individuals with Down syndrome, as well as exhibits, artwork, crafts, products that people have designed. We have also students who are doing research in Down syndrome, present their scientific posters. We have organizations in our local communities that support people with Down syndrome or their families. And it is just a fun time. This year, we had the most number of participants on stage and also exhibiting their artwork. We had 56 individuals with Down syndrome do that. We had the widest variety of performances. We have everything from martial arts to dancing, singing, magic acts. This year, we had cosplay. As well as just a variety of ages. We have children through adults who are all participating. And this year we had 400 people attend this event. So again, this is only our third time putting it on. It's at the Irvine Barkley Theater here on campus every year. And it's such a fun and celebratory and inspiring time. It's drawn so many volunteers from the community. So we've had high school students, people from the community who want to volunteer. So this year we had over 60 volunteers as well.
Excellent. Thank you. So we'll look out for it next summer, start looking out for advertisements for it. Good.
Definitely.
Okay, so we dedicate an entire core in our ADRC to studying Down syndrome. Why? What is the link between Alzheimer's disease and Down syndrome?
So people with Down syndrome have 3 copies of the chromosome 21. And on chromosome 21 is the amyloid precursor protein gene. And so this is also triplicated. And this leads to a 1.5-fold increase in amyloid beta production, which is the origins of what ultimately leads to plaques and tangles that can form into Alzheimer's disease. And not only is the lifelong amyloid beta production happening, beginning in infancy, we already can detect these levels in infants with Down syndrome, but the accumulation begins earlier as well. So as a result, Alzheimer's disease starts earlier in Down syndrome. It also progresses faster in Down syndrome. And given the relatively more homogeneous presentation of Alzheimer's disease in terms of pathology and clinical symptoms, it allows researchers to better understand Alzheimer's disease for everyone, not just people with Down syndrome.
Okay, so let's talk about that. So when do you typically see, at what age do you typically see Alzheimer's disease symptoms develop in people with Down syndrome compared to the general population?
So typically we see symptoms presenting around the 40s, but there have been, in some cases, people as young as in their 30s starting to present with memory and cognitive changes. The average age of diagnosis for dementia is 54 years of age in Down syndrome. And this is significantly younger than in what we call sporadic Alzheimer's disease, or in the general population for people who don't have a genetic form of the disease. And that in the general population, sporadic AD, average dementia diagnosis at 75. So much later.
Mm-hmm. Follow-up question. Does everyone with Down syndrome develop Alzheimer's disease?
So everyone with Down syndrome has the pathology or the neuropathology.
Okay.
And what I mean by that is that we can detect things associated with Alzheimer's disease in their brain at autopsy. So they will have evidence of amyloid beta plaques. They may have evidence of other things like tau tangles, but not everyone will present with those symptoms. And that's what makes this study so fascinating, is why do some people seem to be affected in terms of everyday function much earlier than others, and while other people don't seem to be affected, even though we see the disease in their brain or markers of it in their blood.
You mentioned a term, or you mentioned a term, homogeneous, like the presentation was more homogeneous, maybe. Can you explain that?
Sure. So through all of our studies looking at fluid biomarkers, which refers to things like biomarkers in the blood, as well as biomarkers available in CSF or cerebral spinal fluid, as well as neuroimaging markers that we can see through MRI and PET scans, people with Down syndrome progress through the stages of the disease, and the disease manifests in a very similar sequence. So it's very predictable, and that's what I mean by homogeneous. And this is largely driven because it's a genetic form that's underlying all of these mechanisms, whereas in the general population, there's a lot more genetic variation. And so people could be at risk for dementia or Alzheimer's disease more specifically due to different reasons. It could be, some people have cardiovascular issues or other types of metabolic disorders or other health risk factors that are more unique to that person rather than to the entire general population.
Mm. And then how do symptoms develop differently in people with Down syndrome compared to the general population?
Probably one of the earlier symptoms that happens in Down syndrome is changes in attention and executive function, personality, as well as mobility or gait that don't seem to occur as early in the disease process in the general population. But of course, certainly there are changes in memory as well, and specifically in episodic memory, or being able to remember short-term personal events that they've experienced. Long-term memory isn't affected earlier in the disease process, and a long-term memory is affected much later. And so in the general population, earlier changes seem to be more memory related. And because people with Down syndrome start at a lower level of cognitive and adaptive functioning, the changes may not be as subtle as in the general population. It may really impact their day-to-day functioning much quicker.
I see. Okay. Excellent. And then in terms of tools that you would use in the lab or in the clinic, biomarkers or tools, what do you use and how might that differ from one population to the next or one group to the next?
So the good news is the biomarkers that we look at are the same that are being looked at in sporadic and autosomal dominant forms of Alzheimer's disease. Yeah. So that's what makes studying Alzheimer's disease and Down syndrome so useful, not just for, of course, people with Down syndrome, but also for the general population. And the same markers of amyloid and in terms of PET imaging, as well as plasma p-tau217 that is measured in blood, are also useful for assessing disease progression in Down syndrome. Mm-hmm. But the clinical measures, such as using cognitive tests and screeners, have to be adapted because people with Down syndrome all have intellectual disability. Down syndrome is the primary, greatest single cause of intellectual disability, which means all of them have had lifelong cognitive problems. So we have to adapt our terminology in Alzheimer's disease study for neurotypical individuals. Usually they use the terms cognitively normal or cognitively unimpaired to classify those who haven't been affected by the disease or the neuropathology yet. Mm-hmm. But in Down syndrome, because they're all impaired cognitively, we use the terms cognitively stable or asymptomatic. Mm. We've also had to adapt the cognitive tests as well, because people with Down syndrome never were able to do many of the tasks that are assessed by common dementia screeners or cognitive tests, such as the Clinical Dementia Rating Scale or the Mini Mental Status Exam or the MoCA. So rather than adapting each question on the test, we've developed completely new tests and tasks and measurements of activities that really better reflect what most people with Down syndrome we expect could have done at some point in their lives. But I have to say that Down syndrome also is very heterogeneous in terms of cognitive abilities. While the disease progresses in a more homogeneous way, as I mentioned, there's a great deal of cognitive variability. And some people have mild intellectual disability, and it can go all the way down to severe forms of intellectual disability. So we're not able to develop any particular cutoff score where, if you have 3 or more of these symptoms, or if you've had a 10-point change since your baseline functioning, this means you're now in the mild cognitive impairment or prodromal stages of the disease, or if you've had a change this much, this now means you have dementia. Because again, the starting point is so different. We really have to use the individual's prior functioning level as the main reference point. There is no group level reference point.
Right, that makes sense. So we're differentiating between cognitive function or cognition and function. So how they were doing at home versus how they score on a test. Is that what we're?
Yes. So there's 2 things that we're looking for.
Okay.
Not only cognitive functions, so those are like thinking skills, being able to reason or use language and explain your thought process or what you want, but also functional skills. Yeah. And that's probably another big difference in the general population during the early stages. Prior to having dementia, there should not be any functional changes. And that is actually a core definition of mild cognitive impairment, or MCI, for the general population, is that it's not affecting day-to-day function. But again, people with Down syndrome start off at a much lower premorbid ability. And so any change in cognitive function is going to affect their ability to do things on a day-to-day basis, including self-care or sustaining attention or processing information as quickly as before. So what I was referring to is we often have to compare how they're doing now to how they were doing before, rather than comparing them to this other group, or what we refer to as like the average for all people with Down syndrome. There is no average.
That makes sense. I want to ask you a little bit, because I don't think we went into much detail. Can you tell us a little bit about the ABCDS study, just what it is, what's involved with it, how people can get involved in it?
Absolutely. So ABCDS is the largest NIH-funded study on Down syndrome, period. But it's specifically designed to look at Alzheimer's biomarkers in a natural history study. What that means is there's no interventions happening. We are observing people over the course of the study. And we are now in its 10th year. So we have data on almost 550 individuals with Down syndrome that can be as long as a 10-year range. And we are looking at earliest changes in biomarkers, and this refers to blood-based biomarkers, CSF, and neuroimaging markers of the disease. We're also developing state-of-the-art cognitive measures and dementia screeners to be able to identify which ones are going to be the most useful in clinical trials, or which ones are the most useful for disseminating to community physicians or to other experts, so that they have these tools that they can use in their clinics when they are assessing someone with Down syndrome. As we know, not everyone has a lot of experience with Down syndrome. Not every physician knows the link between Alzheimer's disease and Down syndrome. And so we're trying to help move understanding and awareness in every front, on the research side and the clinical side, and also as well as in clinical trials as they develop therapeutic drugs for Alzheimer's disease. The study is consists of 11 different performance sites or clinical sites that are recruiting subjects, and we're still actively recruiting anyone over the age of anyone 25 years old who has Down syndrome. We have 9 sites across the United States, and then 1 site in Puerto Rico and 1 site in the UK. And participants come in every 16 months to undergo the procedures that I had mentioned. And after each visit, after each cycle, the study team, which is comprised of experts, of course, who understand Alzheimer's disease, as well as who are familiar with the Down syndrome more specific issues, we do what's called a consensus conference to come to a diagnosis, or at least a research classification of if that person is cognitively stable, if they're starting to have changes, what we would call mild cognitive impairment, or MCI, or if they have dementia. And if they have dementia now, what would be the primary cause? Do we think it's primarily related to Alzheimer's disease, or could there be some other factors associated, such as if somebody has some kind of vascular history or other types of medical conditions that might be contributing to the situation?
Great. Yeah, that's a great explanation. And then along those lines, what advances have been made? Because I know some important advances have been made in this realm. So can you talk about those?
Sure. So we know that Alzheimer's in Down syndrome progresses much like it does in the general population. So the biomarker level changes occur in the same order. We now know that vascular pathology has a bigger role in Down syndrome than we previously thought, because people with Down syndrome actually have lower incidence of hypertension and stroke. But yet vascular pathology or abnormal pathology still plays a significant role, which is important to know in clinical trials. We now are starting clinical trials for the first time in history that include people with Down syndrome. And we have good outcome measures for screening people into these trials, as well as monitoring their progress during the trials. We've also found that, I think I had mentioned before, that fluid biomarkers such as p-tau 217 is sensitive to detecting Alzheimer's disease in Down syndrome, as it has been found in the general population. We've also found that tau deposits faster in people with Down syndrome, and as soon as they are considered PET positive for amyloid, which means that on PET scan, the people with Down syndrome already have a certain level of global amyloid burden that is equivalent to 18 centiloids. As soon as that happens, nearly all of them also have elevated levels of tau. And this tau is already spread to Broca regions 1 through 6. And this is quite different than what happens in the general population. Usually there is a lag in time between when someone becomes PET positive for amyloid and when that tau spreads, and when it, not only when tau increases, but also what the timing of it spreading. And so this really highlights again how quickly Alzheimer's disease progresses in Down syndrome compared to the general population. And also the urgent need to find interventions and treatments and to modify their risk for the disease, because it happens so fast. In Down syndrome, the average survival time is what is the technical term used between age of diagnosis of dementia and death is only 4 years.
Wow.
In the general population, for either genetic forms of the disease as well as sporadic Alzheimer's disease, the average survival time ranges from 6 to 12 years.
Wow. You had mentioned previously an important consideration between vascular comorbidities and clinical trials. Can you explain that?
Yes, so many of the drugs that are currently under investigation through clinical trials, one of the adverse side effects is ARIA, which is affecting, is leading to vascular changes in the brain, and that is an unintended consequence of the drug. And given the risk factors associated with Down syndrome already, and knowing that they are more susceptible to these vascular issues, that has always been one of the primary concerns about enrolling people with Down syndrome into these trials, is that they're at increased risk for ARIA, which is a serious and potentially fatal condition. So, experts are trying to figure out that balance of how can we make sure that these drugs are safe and effective in people with Down syndrome, but also minimize risk for people who are volunteering and donating their time and their resources to participate in these trials.
How might findings in individuals with Down syndrome increase our understanding of Alzheimer's disease more broadly?
Well, as I mentioned, because the disease happens earlier in people with Down syndrome, and people with Down syndrome have a much higher risk for Alzheimer's disease. 90% of people with Down syndrome will have a lifetime risk for developing dementia, specifically the Alzheimer's type. So this gives us an opportunity to identify early biomarker changes. And chromosome 21 is a smaller chromosome with limited number of genes. So it allows us to also dissect the molecular basis for what's driving Alzheimer's neuropathology and dementia, as well as what's buffering it. And all of these findings can be generalized to neurotypical individuals. These findings can also lead to prevention studies for the general public, as well as inform doctors of how co-occurring health conditions or lifestyle factors may impact risk and resilience. Yeah, and also because this population is such at high risk for developing the condition, by studying such a homogeneous group of individuals, we're more likely to be able to detect these kinds of signals, as opposed to in sporadic AD, where you have a large group of individuals. Some of them may be at risk for developing the disease, but a lot of people may not. So these are high yield studies.
Yeah, excellent. Okay, we have a few minutes left. I want to spend the last few minutes talking more about like the clinical components of what you do. Maybe, yeah, the care components. So what are recommendations that you have for monitoring, for families to monitor loved ones as they age?
I'm glad you asked. That's such an important part of this whole public education and awareness, that it's really important for people with Down syndrome to have formal cognitive testing in their 30s. And the recommended age range is between 30 to 35 to establish a baseline for future comparison. Families can also, or we actually encourage families to record functional skills during adulthood, what that person can do in terms of self-care, hobbies, their behavioral and social functioning, personal achievements and talents. And then to have annual health checks to monitor for any cognitive, behavioral, or social changes, as well as to treat co-occurring medical conditions as soon as possible. Families and caregivers should watch for day-to-day changes, such as reduced enthusiasm or loss of interest in social activities or withdrawing, as well as increases in irritability or agitation, even false beliefs or accusations that someone is stealing from them. All of these can actually be a reflection of changes in cognition and thinking. But people with Down syndrome have limited communication skills to begin with. And they may also have limited awareness of what's happening. So they, unlike people of average intelligence, they can't tell people, hey, I'm starting to forget things, or I'm having a hard time paying attention or comprehending what you're saying. So it's really important for their family members and staff and friends to observe if there are these changes. The National Task Group on Intellectual Disabilities and Dementia Practices has also created a tool called the NTG Early Detection Screen for Dementia. This is a really useful and easy to use measure available on the website as shown on the screen. It's free to download. It's available in 10 different languages, and physicians, family members, staff can all use this to monitor for changes. There are also other, it's also important for families and caregivers to consider if other changes may be explaining or contributing to these noticeable changes in behavior or cognition, such as environmental, psychological, or medical factors. Any kind of change in staff or roommate, the loss or death of a friend or family member, or even a pet, even something what may be more minor for individuals, such as a family member or friend moving away, not necessarily dying, but even moving away can be very stressful. For someone who has limited intellectual ability and problem-solving skills, having a new job, losing a job, or retiring from a job can also completely change their daily routine and their structure that they're used to. Physical pain and discomfort can lead to behavioral changes, anxiety or depression, as well as sensory impairment. Both hearing impairment and visual impairment is really high in Down syndrome, even in childhood. So we have childhood studies, and as much as 70% of children with Down syndrome already have visual or hearing impairments. And of course, the severity of those impairments can definitely can increase later in adulthood, also corresponding to aging related changes. Some of the behavioral or cognitive changes can also be due to aging, such as increased fatigue or reduced stamina, or being sick or having an infection, as well as more limitations in mobility. So it's really important to get all of those evaluated and treated before coming to a conclusion that somebody may be in the earlier stages of Alzheimer's disease. And it's also important for families to know the adult healthcare guidelines and to bring a copy to their primary care physician or to the neurologist or to the memory specialist that they're seeing. Not all physicians know about this relationship between Alzheimer's and Down syndrome. And oftentimes, unfortunately, we see something called diagnostic overshadowing. And what that means is people who aren't familiar with Down syndrome may misattribute some of these problems as because they're having lifelong intellectual impairment. So they incorrectly attribute everything to having, being intellectually disabled. And so it's really important that families and caregivers educate the experts that they're working with. And so the good news is that there are healthcare guidelines for adults with Down syndrome available through a variety of sites. And Megan's going to place them up on the screen. The American Academy of Family Physicians. There's been a publication in the Journal of American Medical Association, the Global Down Syndrome Foundation, and the National Down Syndrome Society have all published these healthcare guidelines and have PDFs that are downloadable and easy for families and caregivers to read on their own, as well as to give to their treating physicians.
And I will put these post-show in the notes so people can access them. There may have been another one too that I missed, but I will put them in the notes.
Thank you.
Great. So how do you discuss with families prognosis and planning?
Well, again, some families don't actually know about this association between Alzheimer's disease and Down syndrome. So we provide a lot of education about that and the reasons why. And then other families know very well about this and are very concerned from pretty soon from when they know that their child has Down syndrome to certainly as the child gets older and into adulthood. And so we help them understand what are some of the early signs to look at, what to expect over time as the disease progresses. We connect them to local and national resources. We also explain how the individual's needs are going to increase over time. So it's important for them to develop a support network that could consist of the PCP, a memory specialist, caregivers, day program or group home staff, relying on other family and friends. While there's no cure for Alzheimer's disease for anyone, we do have promising findings that greater moderate to vigorous physical activity, greater social engagement, engaging in cognitively complex tasks like through work, can all sort of buffer or maybe even prevent the onset of dementia in Down syndrome, also treating sleep apnea. So we are really starting to find a lot of modifiable health factors and lifestyle changes that we're hoping that, can make a big difference in addition to what's happening in clinical trials and also being able to treat the condition through therapeutics. For families who are now seeing changes and need to plan for later stages of dementia, we talk to them about the importance of creating routines, but still encouraging independence and supporting the individual's friendships and leisure activities. So it continues to give them confidence and a sense of identity. but also now providing more supports like picture or photo cues, structuring activities to happen in the same order to minimize confusion or anxiety, communicating in shorter and simpler sentences, and giving the person a lot more time to respond to questions.
Mm-hmm.
And also they can treat some of these symptoms. Again, there's no cure, but there are treatments available for some of the symptoms associated with dementia, such as the use of antipsychotic medications to treat behavior.
Okay. Excellent. And then are there local resources? I'm sure there are national. Are there local resources available? The Alzheimer's Association, ALZOC, other resources available, maybe specific to the Down syndrome community for support for families?
Yes, so locally, Down Syndrome Association of Orange County is an excellent resource. They have not only a support group for dementia, but also a lot of print materials as well as activities for people with Down syndrome to participate in. And again, to keep maintaining or even increasing the amount of physical, social, and cognitive engagement. They have a book club, they have Taekwondo and clogging and other kinds of dancing, as well as social activities like dances and whatnot. The local Alzheimer's Association of Orange County is also a great resource, and they have resources not just for people or families in the general population, but also specifically for Down syndrome. A little bit further out, the Down Syndrome Association of Los Angeles and San Diego are also available for those who may not be right within our sort of catchment area.
Mm-hmm. Excellent. Thank you, Dr. Hom. I appreciate you joining me today in celebration of Down Syndrome Awareness Month. We'll have you on next year maybe, and everyone should attend the Down Syndrome Showcase next September for sure.
Exactly. Stay tuned and be on the lookout for that. Thank you so much for inviting me to be here today and to share some of the exciting work that's happening in this field and for bringing this awareness to the community.
Yes, thank you. And to our audience, thank you for joining us. If you're interested in participating in research, you should check out the UCI Consent to Contact Registry by going to c2c.uci.edu and join us next month as we have another guest on Ask the Doc. Thank you, everyone. Take care.